Thank you for inviting me and including me in the agenda. I appreciate it. Okay, so I am here. I heard a number of references to our program, so I'm excited that the conversation has already happened, and I hope we can. I'm going to try to save time for discussion so I can get more feedback. But I just want to give you all a sense of what the All of Us Research Program is and where we are in our scientific planning. It's a relatively new program. We officially nationally launched last May 6th, so we just celebrated our first year anniversary. And we really got off the ground in FY16 when we got our first funding from Congress and started to award all of the institutions across the country that are helping us build the infrastructure for this program. So at a very high level, our mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. We did start as part of the Precision Medicine Initiative that President Obama started, although we often say precision health as much as we say precision medicine. So from our perspective, this is really about health, wellness, prevention, as much as it is about enabling the development of treatments. And then underneath that goal, or in order to help us operationalize that mission, we feel like there are three major cornerstones. One is to nurture relationships with 1 million or more participant partners from all walks of life for decades, so we have a really strong emphasis on diversity, but our primary goal here is to enroll 1 million or more people living within the United States and asking them to contribute information and data about themselves for many decades. So we can start to see the course of health across the lifespan. Then to deliver the largest, richest biomedical data set ever to researchers across the country, and the reason why I'm so happy to be here today, to help support the research portfolios of all the institutes and centers at the NIH and other funders across the country. But having the relationship with the institutes and centers is really important because we are a disease agnostic program. Our charge really is to set up the platform and then hope to enable as many studies as we can on top of it. So that's what I want to focus on today. And ultimately catalyzing a robust ecosystem of researchers and funders hungry to use and support the platform. And I'll talk about that a little bit more in my remarks. I just showed this slide. I don't want to go into these deeply because I want to be sure I get to the meat of it. But when we first set up, we had core values that we stuck to that really help us guide decision making in the program. I found in helping to build this program, when you start off, you can have a really solid core set of values. When you start making decisions around policies and build, it's harder to keep to those values. You have to keep going back to what are the core values of the program, and does the decision we're about to make really stick to these? So we constantly are going back to these core values. It's been one of the most important things I think we've developed as a program from the start. I'll talk about a few of these as we go through. And the first one for us is participants as partners, and we've taken this really seriously as we've enrolled. I think we're up at close to 200,000 participants who've enrolled in the program already. And all of those 200,000 participants to us, we want to feel like partners in the program, that they are engaged in the program, not just as participants and sharing information with us, but that they will get information back about themselves. So we've been asking our participants as both members of our governance and making decisions about the program, but also just in our touch points with them out across the country to help us think through what types of data we collect over the course of the program, what lab analyses we will do, given that they will get individual level information back as part of the program over time, what types of researches are conducted, how we return the data, with what educational materials and what mechanism. And then we've been working really closely with national and local community partners, and I have a number of our partners here listed on the bottom, but really asking our participants to be partners in the research. The way people engage in the program is either through our healthcare provider organizations, and we have over 300 enrollment sites across the country made up of different consortium of academic medical centers, the VA, and federally qualified health centers. And then we also have, for anybody who does not live near any of those brick and mortar enrollment sites, we have a website, and you can enroll directly over the website. So that when we say all of us, we truly mean all of us, and part of our charge is getting to participants across the country, regardless of whether they live or are a patient at one of our healthcare centers. So the direct volunteers pathway is a really important way for us to get to people across the country. And here, in order to do that, so this is not a map of our academic medical centers, but we show this map just to show how many places across the country where we have people living where they're not close enough to go in and do the in-person part of our protocol. So we have partnered with Walgreens and Quest and a few other organizations here, including the National Blood Collaborative, to help provide some of the infrastructure to do the blood draw and to collect some of the samples that we need for our protocol. And I'll talk you through the different types of data that we're already collecting on our participants. So here is a walkthrough of our protocol. So again, whether a participant comes in through one of the healthcare centers that we've funded, or whether they come in on their smartphone or on their or wherever they can access the internet, they go through an online consent process. We ask them to go through an e-consent. We have a whole a series of screens and videos that they walk through to explain to them what it means to enroll in the program and what we're asking for from them. Once they've made an informed decision about joining, we then ask them if they would be willing to share their electronic health record data. And if they say yes to that, and we're able to get it, and that's one of the things we're working on in our program is capturing EHR data, which is very challenging, we then collect that information quarterly. So we're getting some of the clinical, some of the real-time clinical data, flaws and all. And then after asking them about sharing their EHR, then we ask them to fill out some core surveys. So we're getting basic demographic information at this point, information about our participants' overall health, their behaviors, their lifestyle, their family history, and their ability to obtain healthcare, so healthcare access and utilization. At the same time, we are continuing to develop survey modules, and one of the reasons why we like to come out and talk to the councils of our ICs and to work with our ICs is to figure out what types of information would be beneficial to your community for us to collect on 1 million diverse participants from across the country. After they've filled out those basic surveys, all online, all through their individual portal that they log into, then we ask them to come in and go through physical measures, and we collect a set of baseline physical measures for right now, and we collect a blood sample and a urine sample, and those are sent to the Mayo, where we have our large freezer where all the samples are stored. And ultimately, we'll be running clinical and environmental assays on those samples. We have not yet done any assays, but that will be available for both our program to run on all 1 million people in fund, and then for researchers to request access to and run assays on over. And that's further off in the future. We don't yet have that mechanism available, but coming soon. And then ultimately, we would like to connect wearables and digital apps to the program as well. And this, again, is our priority of getting information from participants where they sit, so not always having to have participants come into a clinic to get information, but really starting to tap into some of the technology advances and starting to get information from people where they are. We already have a partnership with Fitbit where anyone in our study who already owns a Fitbit can connect that with us, and we have an API, so they just go into their Fitbit account and connect it, and we're starting to collect that data, and we're really interested to see how that physical activity data will be useful in the context of the other data that we're collecting on our participants. We are very imminently getting ready to do whole genome sequencing on all 1 million participants eventually. We don't have all of the folks enrolled yet. Getting our genome centers, we've made awards to 3 genome centers. They're getting onboarded and getting ready to start generating the data. And we're just about to make an award to a genetic counseling resource because we have promised our participants that if we're going to run your genome, we're going to ask you if you want to get medically actionable results back. And if they say yes, that information will come through our genetic counseling resource. We will also be sharing information about pharmacogenetics back with our participants at first. We're starting with those 2 types of information, and over time we hope to add to that so that people can choose to get even richer information back about themselves. But starting with this, and the very first thing we plan to do once we start generating whole genome sequencing data is to do a return of results pilot with 40,000 of our participants of a diverse set. So this is just to show you, I want to switch now from our current protocol to where we see the program going in the future, and I'm hoping to have a little time for discussion with you all about that. This is just to show you how we think about our program, or our protocol. Right now we have a core protocol. We imagine that growing over time and adding data types to the protocol over time, and it's really important for us that we have a retained set of participants that feel engaged and want to keep coming back to the program so that when we ask them to share more information or we want to share information back with them, they're there and they're ready to receive that, and it's really a bidirectional relationship. So we imagine the data types growing over time, and we really want to get a sense of what people would want to, what researchers and participants themselves would want to see collected so that we can start to answer some of our most pressing health and disease questions. This is a diagram not of all of the types of information we're collecting currently, but sort of how we think about the types of information our program could be well suited to collect on participants over time. Looking at environmental data, different biological and clinical variables, behavioral and social. It's very important to us that our study be set up to capture information on wellness, on resilience, on prevention strategies that work, and that we're not just thought of as a genomic medicine program. So it's very important to us to get that genomic data, but we really are also interested in all of these other factors that can, in some cases, in a lot of cases, have an even bigger impact on health outcomes than the genome. So our scientific framework for all of us and how we think of our program developing going forward, I want to give a shout out to our very own Michelle Hamlet, who was the MC for a research workshop that we did last year with folks from across the country. We worked with all of our ICs in doing that. Michelle was maybe the funniest speaker we had for the 2 days, as you guys probably know, having worked with her. We had a whole bunch of folks come into town from all health conditions and disease areas, and asked them if you were to have access to 1 million data points or to many data points across 1 million diverse participants, what are those questions that you would like to be able to ask of a resource like that? And then given that question, what types of information would you need to have on those participants in order to answer it? So that we can start to make informed decisions about should we prioritize a sleep survey or a diet survey or a survey on substance use, and start to make real decisions about how we spend the funding that we have available to us in collecting across 1 million participants. We have had a science committee thinking through what types of information what types of studies we hope our platform will enable. And I just want to point out, this is a pretty broad list, although we do think that over the course of the study, we can touch upon these areas. And I want to point out number one, which is increase wellness and resilience and promote healthy living, and just make the point that we have been working with all of the ICs, and notably with NINR and Anne and Michelle to start to capture some of the information that you all think would be really helpful to have on all of us participants, so that we can really start to get at some of the questions around wellness and resilience. And this is just one, we have in no way made decisions about this, but this is one set of variables, or these are different types of variables that we have started to think about in terms of when we think about what are predictors of health outcomes for acute and chronic disease, and then the individual healthcare system characteristics and lifetime experiences that might lead to wellness. So I'm happy to let me finish up my talk, and maybe we can spend some time at the end talking about what you all think are some of the important variables for us to collect. I think that I'm almost done, so I'd love to leave some time for discussion. So finally, this is the last part of my talk. I want to just talk a little bit about the research access to the data and when it's going to be available. So with the way that we're designing our research, our data set, it's all of the data is held in the cloud. We have Vanderbilt, Verily, and Broad, those 3 organizations who are awarded to hold the data and make it available to researchers. We have both a public side and then a restricted side. So the public side is Aggregate Data, and we just released this publicly on May 6th on our anniversary, on our 1-year anniversary, and it shows aggregate data, and I'll just give you a snapshot of that before we move into the individual level tools. So this is an interactive tool. You could all go to it at any point today, although maybe not when other people are presenting. It's researchallofus.org, and you can see our data snapshots, and it shows you how many participants we have, how many electronic health records we've collected, over 80,000 health records. We have over 146,000 samples so far received, and those numbers just go up as we enroll more people. We're enrolling 33,000 to 3,500 a week at this point. But then you can go deeper into the browser and see information about the most frequent conditions we're seeing through our EHRs. Right now, the #1 condition in all of our participants through the EHR is pain. And you can look at drug exposures, measurements. This is all in aggregate, and we've done a lot of work to make sure that the privacy of our participants cannot be, that is utmost important, so there's no crosstabs. But you can start to look at, I think I have one screenshot. So here's an example. I mentioned that pain is the #1 condition that we're seeing reported in the EHR. And then you can click on pain, and you can see the distribution, age, or sex assigned at birth, and those are the 2 breakdowns that we have currently throughout the browser. You can also look through our surveys and see how many people have smoked more than 100 cigarettes, how many people live in certain areas. So all of the survey questions are now reported in aggregate as well. So it's a fun resource to play with and to start to imagine for your particular research question, would this be a resource that would be useful for asking that in the future when we open up to researchers? So then we get to the restricted researcher workbench, and this is where researchers can request access and get individual level data on all of our participants. It is not open yet. We're aiming to open up this winter, assuming that all of the security testing goes well and that we know that we have the capacity and that the tools perform well. And once we know that and have confirmed that, we will open up to researchers for access. Our primary goal as a program is not to have access ahead of time for any of our researchers, but that the moment we open, it's open to everybody. So that's one of our principles, and we're holding true to that. We will, over the summer, be doing some demonstration projects to demonstrate the utility and the validity of the data that we currently hold and publishing those, but the novel science starts when we open up to everybody and researchers can come and request access. We're working right now on all of those policies, but we do have a general sort of set of a framework for how we're going to be approaching researchers accessing the data. First of all, that data is available to all types of users. It's a cloud-based analysis platform, so researchers have to come to the cloud to use the data. There's no download or taking it to their own local environments. It helps us protect the data if it's used in the cloud. It also allows researchers to collaborate in the workspace remotely with each other in a better way than if they're doing things individually on their computers. The access will be tiered, so we will ask researchers to only ask for the level of data that they need to use for their specific question. We will grant users a data passport, and we're not going to be asking for their scientific summary up front. We're going to be authenticating who they are, asking them to sign a user code of conduct, go through ethics training, and then once they're approved, they get a passport, and they can set up different workstations in the cloud with different queries, and all of their project information, what their data use is going to be made public. And that's law we have in the 21st Century Cures Act that was passed in 2016. By law, we're required to post all data uses as they're happening publicly. So that helps with transparency, and everybody who is contributing to the data set as a participant or the public at large can see how the data is being used. And we are currently working on our policies for access to samples and for access to participants to invite them to other studies. So there might be an opportunity, like what you were talking about in terms of like looking for folks who have been diagnosed with a certain condition and then asking them if they would undergo maybe an interventional study or some deeper analysis or surveys or to enrich the data set in specific areas. And that's really what we're hoping this resource will be good for. That's all in the future as we continue to build the infrastructure, but that's where we're headed. And that's all I got. So I think I saved a little time for discussion. So I'd love to take questions, of course, and I'd also love just feedback from this community of how you could see what we're building intersecting with your scientific goals and priorities.
Thank you very much. I didn't know if you wanted to put the wellness slide back up, if you were trying to ask specific questions about that or not. What I know, part of the reason that we're focused on this today and this content today is we want to make sure our science is reflected in the data that's collected by this All of Us program. So we are, and Michelle is leading this effort for us at NINR, trying to really work with those who have been very receptive in the All of Us program to, talk about, here are the measures that we feel like we would need to use. So just keep that in mind, that today's a short period of time that we can talk about it, but if anybody has other information or other suggestions, Michelle, I think would be very open to hearing those and sharing that with the All of Us program as well. So,
For sure.
any questions at this point or any specific information?
And maybe I'll just add one caveat here,
Go.
that this is very early. This was information that we've just been collecting, so this is by no means, I just wanted to give you guys something to react to, and wellness is one of our priorities, but I'm open to getting thoughts on all sorts of aspects of what you all care about. So, yeah.
This is such an exciting project, so congratulations, and this is an awesome list of concepts or variables. What about self-efficacy? Is that measured within here?
That's a great point. We currently don't have a good measure of self-efficacy, although there are some survey modules that are in the works. We have we pull together groups of experts when we're designing new surveys, and I believe there is one that covers different measures of self-efficacy. And we were just talking about this the other day, and so I believe that's something, we've talked about that a lot internally, and I believe that's something that's coming up. But if you have good measures of that, that would be helpful to know. Yeah.
And one of the concepts I think we're talking about today is activation, and that as well.
What was that?
Activation?
Self-activation?
Is that the word?
Patient activation.
Patient activation, yeah. Yeah, like are they willing to make changes in their life to be healthy?
I see. Sure.
Thank you. I just wondered, in terms of the symptom measure, you're collecting symptom data, correct? Are you using the PROMIS measures, or are you using some of the standardized measures that are already available?
So we have not yet connected. We've talked about PROMIS measures, but we haven't yet connected with those folks. Currently, we're getting symptom information as part of self-report to a small extent, but largely through EHR currently.
And it's too late to add on, I mean, it's set, is the...
No,
it's not-
our protocol, the way that we've designed it is that we really do want to add on measures over time. We tried to set a reasonable core protocol to get started so that we could start enrolling our participants and collect a baseline set of information. But our intention is to have an engaged relationship with them over the long term so that we can go back and ask for, new measures over time. That will obviously depend on funding and other things, but yeah, our protocol is in no way set. This is why we're working so closely with the ICs and trying to figure out what are the next things we want to collect on participants.
I think there's a lot of interest across NIH institutes and elsewhere in LGBT health.
Yeah.
And I would hope that would become part of the areas in which you'd gain information about people.
Yes, definitely. Thank you for that. We have a really strong community partner so we have we have 5 national community partners and about 35 other community partners, but 5 that are funded by our program to help us develop relationships with their communities. And one of the groups is based out of Stanford who works with the LGBTQ community. They've been a really strong partner for us. And I think we have somewhere of upwards of 10% sexual and gender minorities in the program. And you can see that on the data browser, but we have been doing a lot of work to engage bidirectionally with that community and be sure that we're capturing the right information from the start in order to answer questions. Thank you for that.
Wonderful project. I was wondering if you can speak to the inclusion of children in the future iteration.
Yeah, definitely. So from the very beginning of the program, we said that one of our priorities was to enroll children, but that we were going to start with the adult protocol in order to get ourselves going. But the idea of the program is for it to really be a lifespan program. So we want to be able to enroll everybody in the program. And currently, our only eligibility criteria are that you have to be over 18 and you can't be incarcerated because we haven't gotten IRB approval for children or individuals who've been incarcerated yet. But our intention is to keep knocking those eligibility criteria off until we have a fully inclusive program. In terms of children, we've been working internally on the protocol to get birth to 6 off the ground, and then we'll move to 7 to 12 and 13 to 18, understanding that there are different measures we'd want to collect at those different phases of children. So we've had a number of experts helping give us advice on how to do that and what survey questions we'd want to answer, and to think through some of the policy issues with children and their parents and privacy and consent and assent. So we're working on all of that. It's been behind the adult protocol because we wanted to get started, but it is still a huge priority of ours to get children included. And maybe I'll take 1 second to just mention diversity. I'm so sorry, and then we'll get to your question. To mention diversity, because I talked about it, but I didn't really share any of our numbers. So one of the things that we've focused on as a program is to really enforce diversity of the people who are enrolling in the program. And we had a goal of 75% of folks in our program being in at least one category of underrepresented in biomedical research. We're at about 80% of all of our participants hitting at least one category of what we call underrepresented in biomedical research, and that's across a bunch of different categories. So it's race and ethnicity, age, the very young, not very young yet, but the very old. Geography, so folks in rural areas are typically less represented in research. Sexual and gender minorities. There's 9 categories in which we're tracking who has been highly represented in the past and who has not been, so that our data set can enrich for some of those communities that currently are not available in data sets open to researchers. And we're at about 51% racial and ethnic minorities in the program. So we're really happy about those numbers. Yes.
Sort of as a piggyback on, with this, I'm curious, being Native and being a Native American investigator, knowing the resistance to some of the data with the context of historical experiences.
Yeah.
I'm wondering what's been the experience with being able to obtain Native American.
Yeah. Yeah, thanks. Yeah, thanks for the question. In fact, we've been working really closely with the Tribal Advisory Committee here at NIH on just that, on just the plans for we have not yet gone through the full consultation process with the American Indian Alaska Native communities. So we're just about to start, and our first consultation is not until June 24th. So our work with the Tribal Advisory Committee has been helping us get through, all of the consultation and engagement until we have a set of recommendations that we can respond to as a program. Until that point, we have been allowing folks to enroll in the program and self-identify, but we have sort of agreed to not enroll participants from tribal lands until we've gotten to an agreement. Yeah.
Could you tell us a little bit about the data, how frequency of data collection and what participants agree to?
Yes. So currently, our participants agree to the protocol I outlined before of sharing their electronic health record on a quarterly basis, and that's a direct ingestion. Yep. And that in the case of where we have relationships with their healthcare providers, that's easy. In the cases where people directly volunteer from out in the country and we don't know their provider, that's harder. And we're working on different strategies for getting that data. And then the surveys, and we've asked people to be prepared to come back and answer surveys over the course of the study. And then we do one-time physical measures currently and one-time blood draw. But we've also, in our consent, said over the life of the study, we would imagine asking you to come back for future biospecimens. And this is where the building happens, because we just haven't made decisions yet of what reassessments we're going to want to do over the life of the study. And we have a science committee who's helping work through that, and we're working with the larger NIH community to figure out what things we want to assess once and what things we want to assess, over time to capture change. So currently, it's just the protocol that I put up in the slides. Although, I'm sorry, one last thing. As part of the consent, they are agreeing, they're notionally agreeing to be part of the study until they withdraw, but our consent is designed. We're hopeful that you as a participant, if you decide to sign on, will stay in the study as a longitudinal study.